forearm, your bicep, your shoulder girdle have to work in synergy. It's not a single movement. So when you grip here, the GH is involved. When the shoulder girdle is involved, this is involved. So if you have dysfunction here, it's always worth looking here, and if you have problems here, it's always worth looking here. That being said as well, the shoulder and the scapula have a specific ratio of movement. Does anyone know what that is? So it's like a 2-to-1 ratio between the shoulder and the scapula.
Like 120 degrees, and then it goes all the way.
Yeah, the ratio between the movement of the GH and the movement of the scapula. They work together. Okay.
Till some point, right?
Yeah, absolutely.
1-to-1.
Absolutely. So, for example, if there's shoulder dysfunction or a problem in the shoulder, and there's a reduction in the movement of the scapula, then there's going to be an issue with the rib angle. There's going to be a dysfunction in the thoracic, into the cervical spine, and vice versa. So it's actually quite a complex joint. The majority of tests for the shoulder are poor. Okay, so the majority of actual diagnostic tests for the shoulder, or this sort of movement, is actually quite poor in its diagnosis. We were working with a specialist physio who focuses predominantly on shoulder dysfunction, and in its simplistic of terms, if we take out things like trauma and stuff, their advice is for most general shoulder pain, if you strengthen the posterior aspect of the shoulder girdle, you tend to have a very positive effect on the shoulder itself, because most people tend to be very weak here, strong here and here, and most general dysfunction, if you strengthen the back with your high pulls, reverse flies.
Lower posterior deltoid and teres.
Yeah. Basically, they would say the posterior cuff, the posterior shoulder.
Fine, yeah, okay.
In most sort of generalised MSK issues. Now, the shoulder loves a bit of traction, so things like adhesive capsulitis or your frozen shoulder syndromes, a little bit of traction to the shoulder girdle to start helping with that imbibition of the joint. Okay?
Also for impingement?
The AC is a different ball game. It's a little joint. If you have problems with the acromioclavicular, there's not a massive amount you can do, to be honest.
Also for impingement?
Yeah, all that sort of stuff. So we're looking at things like impingement syndromes, generalised shoulder pain, things like that. So this is a nice little way we can start adding some movement into the shoulder girdle. So you want a patient on his side, onto your side. I tend to support the leg a little bit, bring it up, so it's in a bit of a comfortable position. If they've got lower back pain, for example, you can bring the knees up, take some pressure off the lower back. It can be a little bit more comfortable for the person. Now, I want to add some traction, and also I want to add some circumduction. So I want to get the shoulder moving nicely. Now, he's a big guy, heavy arm. I want to make sure that I'm using my body weight effectively. Okay? So what I'll do is I will take the arm, if he's able to, and I will put my arm underneath, and I will brace his elbow against my chest. But can you see how I'm going to just squat down slightly? Okay? So I lock it in. This is going to allow me to secure the arm, and then all I do is I will step up. Yeah? So I lock the elbow against my chest, I squat down, I secure the forearm, and all I need to do now is I need to step up. And can you see, with my legs, I'm getting a really nice traction into the shoulder girdle without me having to drive or drag using my upper body. It's all about the legs. So again, we lock in, secure the forearm, nice and tight, and I will step up. But from here, all I need to do to add additional is to create a pump movement with the forearm. So we start to traction even further. But we don't just stop there. All I need to do from here is add a sway technique with my body. So we have now traction and circumduction without any pressure on us, because all the force, look, one-handed, is going through my legs. Yeah? But we don't just stop there either. We can start working in you've done your P&Fs and METs. We can take hold of the elbow, just hold it down for me. Secure, and we can start to work through.
Nice.
We can get him to pull down. Just pull your elbow down for me. Just less. breathe in, and as he breathes out, I stabilise, and we can start to take it through a range of movement. But we know the shoulder, scapula and rib will work in synergy. So from here, I shorten, hold on to my elbow, there we go. I'm controlling the arm, and look, I shorten, lock into the rib, and I can now start to open out. So we are working on the rib angle. But from here, we need to think about the scapula. So all I do is step around. I place the hand behind, and look, we can get the scapula to pop. I can lock underneath. I can control the head of the humerus if I want to keep it local and start adding scapular movement.
Why not from the back?
You can, but I find it easier for me to control him. Look, I push down, the scapula will pop. I can lock in and under because I may want to reinforce the joint by locking with my chest and picking him up. I can't do that from the posterior aspect as effectively. Yeah, but you're compromising your lumbar spine. So for me, look, I can lock it in, I can lick it up, and from here I am adding circumduction quite comfortably. But bear in mind, I may also want to look at the C17-1. So lift your head up. And I can now add that side bending movement without having to run around the couch too much. Okay. So I've positioned myself quite easily in two different angles.
This is good for the diet.
Absolutely. It's about making it easy, because then we would come into lumbers, yeah? Well, all that sort of stuff. So it's about making it quick for you. So let me show you that again, all right? Because I've done quite a lot there. Okay? So let's break it down. Don't worry, I'll show you. Place the arm like so, underneath, and I just want to push it against my forearm. I want to use my legs. So I will brace it in and I step up. I can now add traction and circumduction, like so. If I want to then work into the rib, I need to start thinking about taking the arm over. So I will secure, nice and tight, a nice good solid split stance. I lower the elbow, I lock the rib down, and from here I can start to open it out. And I just work along the rib angle. We can create an MET by just bringing the elbow down, securing the head of the humerus, and taking it through. Get the patient to resist and start to stretch further. From here, we secure underneath the scapula by bringing the head of the humerus down, locking under, and adding the circumduction to the scapulothoracic. We can secure and make it even stronger with an additional purchase compressing against our chest. Remember, my body positioning is not compromising the patient. And from the scapulothoracic, remember yesterday with the cervical-thoracic junction, we can place lateral pressure against C17-1 and start to open it out into side bending or into extension and flexion. So we've worked.
Can you show the side flexion one more time?
So literally, I'm just going to push his forehead into my rippling biceps, and then I'm going to apply a little bit of pressure on the C7, and all I do is I lift it up. I can hook under with my finger, and all I'm doing is stabilising. I'm not affecting the joint, just to feel the movement, and then I can take the head into extension or flexion quite comfortably without compromising my space.
When you do that, you're doing extension or like a shift?
Just a shear.
Yeah,
It's just a shear movement. So you can see, literally within 45 seconds, I've worked on the GH, I've worked on the scapulothoracic, I've come into the rib, and I've done a little bit of work on the C7T1. Boom. All right? So what I'd like to start off by doing, let's start off just getting you into the shoulder, get the traction, the circumduction, and then when you're happy, we'll start moving on into rib.